The future is in combinations. And the reason is for what I said a couple of minutes ago, where as the single agent in relapsed and refractory disease, you get high response rates, but the duration of response is relatively short. So one way to fix that problem is to combine an active drug with standard of care therapies. There are already a number of phase 1 or phase 2 trials that are combining revumenib or other menin inhibitors with standard of care intensive chemotherapy, like 7+3, and also with standard of care lower intensity therapy like azacitidine and venetoclax. In fact, those trials are so far along that I think every company who has a menin inhibitor, or the majority of companies that have a menin inhibitor, have invested heavily in performing randomized phase 3 studies to see whether the combination of Aza, Ven, and menin inhibitor is better than Aza, Ven as a doublet, and whether the combination of revumenib or other menin inhibitors with intensive chemotherapy is better than intensive chemotherapy alone. I mean, the last thing I'll say about this is that we're now talking about doing quadruplet studies because we now have targeted therapies that can potentially be combined. So, for example, if you had a patient with a co-occurring NPM1 and FLT3 mutation, there's actually a study up and running out of the Dana-Farber Cancer Institute that's combining 7 and 3 midostaurin, the FLT3 inhibitor, with revumenib, for NPM1 mutant disease. So we're going to be seeing, I think, a lot of these studies that are trying to mix and match a lot of agents together. And the question is going to be, what's the best way to do that? What are the response rates? How do you tease out the components of each drug and which one is most important? But I think that's provided a lot of things for us to do over the next 2 to 5 years.